an absolute honor to be able to kick off the welcome and inaugural lecture for Professor Stefan Listl. Many of you know Stefan, some in detail, some in superficial detail. So fantastic to celebrate today Stefan's oeuvre, scientific achievements, personal achievements at high. We are absolutely thrilled, Stefan, to have been able to attract you to the High family. You're already settled, you're already up and running, highly productive, and it's an immense honor and a massive benefit for High to have you as one of our professors and faculty, and to have you lead a large and growing team on research unit on translational health economics, but also on oral public health. And as you may know, oral public health is a niche subject, but as I will show, in a massively important topic. So a theme that has future, where there are very few global players, and Stefan is one of the 5 leading lights in oral public health. And his background as both a dentist, a fully specialized and clinically trained and licensed dentist, but also as a bachelor, master, PhD carrying, fully card-carrying economist, with a PhD from Germany's best university in economics, which is Mannheim University next door, as many of you know. So it is the place to learn causal inference, econometrics, macro, micro, and Stefan comes from that school and brings the domain expertise deeply in dental health, oral dental health, dental implementation science to High, but also the methods expertise in economics, econometrics, implementation science. So a big gain for us. Would you switch on my presentation? Thank you. So I would like to give a short overview over Stefan's most impressive oeuvre, and clearly as an economist, Stefan works on the economic impact of all diseases. We have the great pleasure today that also the lead at WHO of the WHO Dental Health Unit is here, Benoit, and he is very welcome. We are thrilled, and it's an honor and sign and signal how important Stefan is in the global world of oral public health, that WHO is fully represented, and Stefan has worked with WHO intensively for many years, is currently on committees and commissions, and he has contributed in the scientific steering committee of the Global Oral Health Status Report, important policy movements which are still ongoing and now also being fed increasingly by an empirical research agenda that Stefan and others close in his network and team are leading. And he was one of the co-authors leading the writing of the economic rationale for global investment in oral health. It's a massive rationale from the World Economic Forum, which, as you know, is one of the major power-playing institutions in global economics and the way our societies function in global togetherness, but also strife. So the World Economic Forum knows who to select if they need a report like this, and they select Stefan. Stefan is incidentally also a commissioner on the Lancet Commission on global dental health, oral public health, with the 20 or so global experts in oral public health. And we very much look forward. As you know, the Lancet Commissions are one of the major outlets taking us scientists. They're scientifically led, but Lancet asks us to make major policy recommendations. As you may know, High currently is part of 23 Lancet Commissions and Lancet Countdown and similar Lancet initiatives. So Stefan, it's fantastic that we have this outlet into policy through you also in dental health. And here is the data from one of the reports that Stefan has contributed to, where we look at the per capita dental health expenditures, and you see this massive gradient in the world. It's a gradient we see again and again, but it is maybe starkest in dental health, because to some extent, wrongly, dental health is seen as a luxury service. And you see here it ranges from countries in Africa, West, East, Central Africa, that spend less than $1 per person per year on dental health. And then you see the expenditures in high-income contexts. Germany is part of that, Northern Europe, Canada, and the US, where more than 300 euros dollars per year are spent per person on dental health care. So a massive provision gradient in this world that, of course, reflects, if we travel globally, we see the dental suffering of people in resource-poor communities. And that is a social justice motivation for the work that Stefan does. And then, and this was very surprising to me when Stefan shared this data, I would have guessed dental health is a major area of healthcare spending in most advanced economies, but I wouldn't have guessed that it is the third biggest one and very close to other ones, which all of us would have seen as major spending domains in health systems, diabetes and cardiovascular disease. But shortly after, only 20 billion less here in the EU 28, at the time with the UK, now EU 27, 90 billion for dental diseases per year. That is massive. It's more than the GDP of many countries. So dental health is an important arena, and one manifestation of that importance in public health is, of course, the spending. And therefore, Stefan also, not surprisingly, works on financing in dental health care. And of course, as you know, we have already very strong teams with Manuela and colleagues on financing, healthcare financing at HEI, but Stefan also brings the particular domain of dental healthcare finance into the mix. And here are some examples. They're really, really powerful because they are causal, and it is the type of research that we have far too rarely, given our sort of stylized understanding how healthcare payment systems work. So here Stefan looked fee-for-service versus salary. We are replacing a salary, just the time you spend doing a dental x-ray with fee-for-service, and expectedly, but fantastic to show in strong empirical work, the utilization goes up of dental x-rays. Really good to have such strong data. And here, similarly, very interesting study in health economics. These are incidentally the two top journals in health economics. Journal of Health Economics #1, Health Economics #2. Stefan publishes in all of those. And here he looked at a healthcare payment reform for dental care with major changes in treatment claims, how they're being done in Denmark. And he finds that the treatment claims are changed, but the treatment and recall intervals aren't. And Stefan is currently leading a large EU consortium, Prudent, on implementation science, prioritizing, incentivizing resources for sustainable dentistry, and that ranges from better needs assessment, better adaptation of services to needs, to monitoring indication, but also to on-the-ground service reform and changes. A powerful project that takes him, as in many of his other works, also into trials. And at Heil, that's again a wonderful fit for us because we do trials in 3 major places: in people's homes, population-based, in communities, collective, community-based, but also in health systems. And that is what Stefan practices very strongly. So here's one trial. I really look forward to seeing the results. What a fantastic opportunity to do these payment reform trials, randomizing providers to different ways to receive reimbursement for dental care, fee-for-service, the status quo. And this is where many European health systems from the 50s, 60s, 70s came from. And then all the ranges of payment reforms, experimenting, learning, and we are in very mixed systems today. But here, as one of the first trials worldwide in the domain of dental health, a trial to see if capitation leads to a major change. Capitation, as you know, is I pay you per case. You receive a case and you commit to treatment, and for how much it takes, how much it costs, you receive the same amount. You cannot come back with claims, fee-for-service, and do more and therefore get more. So it is a capitation-based intervention. And even more interestingly, because it is based in the Netherlands, where the underlying epidemiology shows that caries, one of the major 2 public oral dental health problems, caries and periodontitis, is massively more strongly occurring, an increasing gradient in resource-poor populations within the resource-rich overall Netherlands. And now the capitation is actually context-specific, SES-specific. A child from a poor family treated for caries is more lucrative to the dentist than the child from the rich family. So what a fantastic idea as a policy experiment, and what a fantastic study. We look forward to the results. Here is another example of this stream, causal, experimental, in this world, implementation, intervention research, where Stefan looks at new ways to integrate the treatment between diabetes and periodontitis. Of course, diabetes causes periodontitis, but periodontitis and dental healthcare, therefore, can also be an entry into diabetes screening, diagnosis, and treatment. So that integration between dentistry and diabetes is powerful. And then the last and maybe most impressive stream of research that Stefan is leading is in the causal determinants of dental health world, which is modern social epidemiology using the instruments and approaches of modern causal inference. And Josh and Guido won the Nobel Prize in Economics for it in 2021. Guido, 10 years ago, I called him, and a day later, we had a coffee at Harvard Square, and he reassured us we wanted to use regression discontinuity for a survival analytical outcome, and no one had ever done that. And the method didn't exist, and Guido reassured us and said, well, it's a trial, quasi-trial, do it. I will prove for you later, he's never done it, but he promised we'll call him up again, that this is actually valid, right? That it's an unbiased, efficient estimator. And this is a joint feeling of pain, Stefan. We've discussed it often. It's still a little bit an uphill struggle in European epistemic communities to work with modern causal inference, but Stefan has succeeded. And here he writes very early on causal inference, onward and upward, and of course applies causal inference strongly to dental health. And I've 3 absolutely fantastic examples that show the strength of strong causal inference here. This is real-life causal research. We are not there when this trial happens. Nature experiments for us, and it depends, of course, on the gift of an instrumental variable, for instance, or the gift of a regression discontinuity setup. So it depends on these gifts, and here the gift is the schooling reform in the UK, and Stefan uses that as an instrument to instrument educational attainment, and now looks at the outcome edentulism, the loss of teeth, and sees that 1 year of education leads to a about 10-point lower probability of edentulism. And in a similar way here, or a similar question, it's an old narrative in medicine. Many of us who are medics are familiar with it. Albrecht from the OBGYN situation. Of course, a child is demanding on a mother's somatic health and draws calcium into his or her bones, the child from the mom. So there are many plausible mechanisms why another child can lead to tooth loss later in age of the mum. And we have, of course, huge endogeneity issues here unless we have an instrument that we can use to instrument the number of children that a mum has. And here the instrument is the sex of the first 2 children in the UK. And the idea is, and that's testable empirically, and Stefan finds it to be true, the idea is that there's a very strong preference amongst parents in the UK at this point in time to have one of each, a boy and a girl. So if your first 2 children are boys, or if your first 2 children are girls, you go again. If the first is a boy or a girl, you think twice. And that works, we can test that, and Stefan here sees that the old wisdom, gaining a child, losing a tooth, does indeed hold true in empirical data, nationally representatively in the UK. So fantastic work, really, really amazing, and it was therefore featured widely in the media here in the Telegraph. Gain a child, lose a tooth, old wives' tale is true, study suggests. And And the last one here, again, a very good instrument, which is the differential childhood exposure to fluoride in your drinking water. As you know, this is a globally controversially discussed in public health circles topic right now. On dental health, it is not controversial that it helps. What is controversial is the cognitive effects on child development of increased fluoride. In Germany, we don't have fluoridized water as a standard, but in many other countries we have, and in the UK it varies by state, and Stefan can use that as a quasi-experiment to identify the exogenous variation in tooth health, and can therefore look on the effect of tooth health onto mental health. And here he finds that losing 10 or more teeth, that's a lot, very visible, but it is as significant for your depression as not receiving antidepressants. So it's an effect size that is massive. It means essentially as big as untreated depression. So teeth are important for our mental health, and fantastic to discuss with you. I'm very interested in that topic later on. What are mechanisms and how can we help, right? How can we support people here? The new mental is the old dental. Is that how you say it? Or dental is the new mental, something like that? Yeah. And to end, a few basic facts about this place and about Stefan. You may know all these facts, they are quite clear. So behind me, visible, is Marsilius. And Marsilius is the founding rector of Heidelberg University, right? He's the direct predecessor of Frauke Melchior, our current rector, and we poached him in a Brexit-type situation from the Sorbonne. And now he builds Heidelberg University, and there we are today, and there are long stretches of history where this university was the globally leading university. So Marsilius is an important starting point. And Marsilius is not only pictured here, he was born in Nimregen in Holland and has a very interdisciplinary focus in his initial envisioning of Heidelberg University. So even in the founding documents, the focus was interdisciplinary. The disciplines weren't as many, but there was medicine and dentistry, there was law. Now, of course, there's engineering, which didn't exist, and many others. And Stefan is a descendant of Marsilius, very clearly. So he's been a professor in Nimregen, as you know, and is placed physically in the Marsilius Arcades, named after Marsilius, and is also strongly interdisciplinary. That's why it's also such a fantastic fit, Stefan, for High. We are a deeply transdisciplinary institute, and your scientific vision, your style is perfect, and it's really exciting to have you at High. There's an even deeper history when we look at dental continuation in Heidelberg. You know the Homo heidelbergensis, who is a direct predecessor to Homo sapiens, which Stefan is a wonderful example of. This is Homo heidelbergensis as we think he looked, not Stefan, slight resemblance. And here is his jaw, right? And teeth survive, and teeth are in archaeology and in anthropology a very good tool to trace over time the exposures that people have that are health relevant, right? We can read a lot out of teeth, and they survive. They survive really human history, as we see here in this example. And I'm very excited to embark or be a little contributing part, Stefan, in your massive investment also in looking at the link between dental health and human and social development. It's an exciting agenda. I think we could be world leading here at High, and I'm deeply honored and grateful that you have joined us, Stefan, and welcome, and over to you.
So I just need to fix the techniques here. Give me a sec. Okay, good to go. So thanks very much, Till. You put a really big smile on my face. But the topic of my talk is broken smiles. So not everyone has this big smile as I had a few seconds ago. And the reason behind that might be because they suffer from oral diseases. And that's the focus of the talk also. So what I'm trying to focus on is what oral health tells about society. And this talk has 3 parts. In the first part, I want to motivate why we should bother about oral diseases and oral health more broadly. The second part zooms into the root causes of oral health systems failure. And the third part is looking ahead. So what we might see in the future and what our team is set up to do in the future. Any comments, questions, complaints? Please don't hold back and ask. So broken smiles, why should we bother? And I've brought some pictures just to set the mood. So maybe let these pictures sink in a little bit and try to imagine what oral diseases do to people. So think about how do they eat, how do they speak, how do they socialize, is it easy for them to find a job, how do job interviews work for them, and then maybe consider whether this is a minor issue or maybe it's a major issue for people in their daily lives. And in the end, who's responsible actually? Is it only them? Is it their own fault that they suffer from oral diseases? Or could there be other things? Is there a more social responsibility? So just to set the scene, just to set the mood, I hope these pictures helped to get some thinking. So is it a minor issue? Looking at some data, they clearly suggest no, it's not a minor issue. It's a big issue. So from the Global Burden of Disease study, we see estimates suggesting that more than half the world population is suffering from oral diseases. And these diseases include caries, periodontitis, and tooth loss, but also oral cancer, which is very lethal, and cleft lip and palate, and NOMA, which we mainly see in low-income countries. WHO released a resolution on oral health in 2019, pointing out that this disease burden is highly avoidable because it's mainly due to modifiable risk factors, and also pointed out very clearly that there are enormous social inequalities, and these relate to access to dental care, to unmet oral health needs, and also catastrophic expenditures. Till already brought this up. So this is work that our team did over the last few years, and it reached some impact. So the numbers on the global economic burden of oral conditions, and our most recent estimates suggest that it's in the size of $710 billion US dollars per year. Thereof, treatment costs in the ballpark of a bit more than 380 billion US dollars, and productivity losses a bit more than 320 US dollars. This is each and every year, and this is really a major economic burden. And Till already put this into perspective, comparing it to comparing treatment expenditures for dental diseases against diabetes, cardiovascular disease, and so on and so forth. Another consideration is very often people outside the oral health field think that oral diseases are a very separate disease entity. They have nothing to do with other entities or any other diseases. But this is not true. So there's an interplay between oral diseases and other conditions. So this is taken from an umbrella review looking at the literature on correlations between oral conditions and other NCDs. The thicker the lines, the more literature is out there. And you see the most literature is looking into the correlations between periodontitis and diabetes and periodontitis and cardiovascular diseases. There are common risk factors like sugars, tobacco, and alcohol, So strategies which address these risk factors have a high likelihood of not only improving NCDs like diabetes and cardiovascular diseases, but also improving oral health conditions, in particular periodontitis here. So it is important to understand that, in order to understand that oral diseases should not be considered separate from other diseases, but should really be an integral part of larger NCD strategies. Along these lines, we see more and more recognition also of oral diseases and oral health. So not too long ago, the Director General of WHO, Tedros, said that there is no health without oral health, which is a strong statement. The Lancet, Till already mentioned, had an oral health series published, very much emphasizing that oral health and the mouth is a fundamental feature of personal identity. And more recently, we saw WHO releasing an action plan on oral health, which is up to the year 2030, reiterating the high burden of disease, that this is largely avoidable, and also the high treatment costs, and setting for the main goal to have universal health coverage for oral health. But the big gap is really how we can improve oral health systems. And that's what I want to zoom in on now. And the way I'm going to do this is I'll explain some root causes of why we see oral health systems failures. So I have 4 root causes listed here, and I'll explain them one by one in the subsequent slides. And I just for the overview, the first root cause is a lack of accountability for citizen values. The second root cause is a disconnection of oral health versus the broader health community. The third risk factors we call path dependencies within the oral health policy ecosystem, and the fourth and last we call an idiosyncrasy of the dental research and the academic ecosystem. Bit complicated wording, but I hope I can explain and make that clear in the next few slides. So zooming in on the first root cause. So this is what we call a lack of accountability for citizen values. In general, I think it's fair to say that there's a limited awareness for the social value of oral health. We rarely see the voices of patients and citizens represented in policymaking and then advocating for oral health. And that makes it difficult to set a normative goal for why to pay more attention to oral health and how to improve the oral health conditions of those affected. That means the interests of various stakeholders are difficult to align, and in the end, this lack of synergies strengthens, complicates the strengthening of social accountability. Here's a quote from an editorial in the Journal of the American Dental Association. By coincidence, the author is here, Michael is here. This was pointing out very clearly the absence of patients' voices. And this is referring to a high-level UN declaration on NCDs in 2018, where oral health was not even mentioned once. And Michael has made the case that this is unacceptable, and it's really not understandable why we don't see oral diseases pointed out more clearly in documents like this. Now, this was in 2018. We are now in 2025. There's regular updates, there's regular new documents coming out, and every time there's tension and we're not sure is oral health mentioned. We've seen this year again, like in an earlier draft, oral health was not mentioned. Habib is here today, also pointed out in the editorial very clearly, and I think this had impact on the reintroduction of oral health, and we now see it again mentioned. Not centrally, but it is mentioned in the final document, and next week there's the next meeting in New York, and everyone is looking at this with a bit of anxiety, but also with a bit of hope. I think we're still up for making the narrative more clear and more strong. And perhaps we need to consider storylines like this and position oral health more strongly against stories of other diseases, other entities, which have emphasized more clearly the impact on mortality. So perhaps the question to ask is whether oral diseases are a silent killer. And then there's 3 potential pathways to highlight. So one could be the classical biologically focused pathway focusing on systemic inflammation. So that's the pathway that most clinical research in dentistry focuses on. But maybe we could also consider a pathway more directly through malnutrition. And then the 3rd pathway, which I find most relevant, is the social stress pathway. The impact that oral diseases have on people in their daily lives and how much stress that causes to them and what that means for social isolation. And in the end, all this stress load contributes to mortality risks. So that was root cause number 1. Root cause number 2 for health systems failures. This is the disintegration of the oral health community from the broader health community. We all know, assumingly we all know, dentistry and medicine evolved as really separate professions. We see this in universities. Dentistry is a really different degree from medicine. So there's a cultural separation very early in the academic curriculum, and that doesn't help for more crosstalk and better integration. And I think this is also like a reason why oral health is often forgotten in NCD strategies. And in the end, that leads to failure on all levels. So we see really disintegration on the practice level, disintegration on the community level, and on the policy-making level. So this is cultural. So this is really hard to break. And I think like more integration in dental curricula and with medical curricula would really be helpful. This is just an example taken from the BMGA. I think this was referring to Habib's editorial making the point that dentistry and medicine evolved as separate professions. And this has been creating educational and institutional silos that left oral health seen as specialized, but not integral to overall health or health systems. Okay, root cause number 3 is termed path dependencies within the oral health policy ecosystem. Just stating there's major room for improvement in financing arrangement. There's a lot of financing arrangements in the oral health field are historically anchored just because some decades ago, out of pragmatic reasons, financing arrangements were made in a way which were practical back then. And that has continued, we still see similarities or very strong historical anchoredness of current financing arrangements. Till mentioned fee-for-service. This is still the mainstay of payment systems. This is just one example. We also see opportunistic policy-making narratives, and I'll give an example in a minute. And we also see a dearth of oral health policy evidence in general. Like most of the oral health research is focusing on clinical decision-making processes, but there's very little literature which focuses on policy-making processes. So here's an example referring to financing of essential medicines. So this is on the affordability of fluoride toothpaste. Fluoride toothpaste is considered an essential medicine by WHO. And here we did a survey and looked at, like, can people afford fluoride toothpaste? I think in high-income countries, we just used to, okay, fluoride toothpaste, that's something very affordable, very cheaply available in supermarkets, readily available, easy. Now the reality check, looking more globally, particularly low-income countries, tells us something really different. Now, on the left side, you see New Zealand, and on the right side, you see Zimbabwe and Benin. So it's a massive difference in terms of affordability. So the number of daily wages that consumes, and that refers to the lowest paid unskilled government worker, is massive in low-income countries, shown here. So that means for an essential medicine, and this is really important for people to maintain good and secure good oral health, the affordability is not easy in low-income countries. And that raises questions around what type of product is this actually? It's usually a cosmetic product, while it's at the same time considered an essential medicine, so that has implication for how the product is taxed. There's also a black market for fluoride toothpaste. Yeah, there's a lot of difficulties and complexities. How to get access to something we consider easy in high-income countries, fluoride toothpaste, how to make it available in low-income countries in a way that people can really afford it. I mentioned opportunistic policymaking. So here's something we published very recently. I think Siad is here today, like our first author of this paper. And this is an example from the Netherlands. So there's a lot of discussion in the Netherlands currently whether there should be more public coverage for oral healthcare. And over the last 20 years, the coverage for oral healthcare has been reduced. And now policymakers have been arguing that reduced public coverage did not decrease dental visits. We were wondering, okay, like, does this actually hold true? There's not so much data available to do such analysis, which is another complexity. But we could work with some official statistics, and actually our results suggest that, contrary to what policymakers were arguing, that reduced public coverage led to fewer people visiting the dentist in the Netherlands. So this is a bit of debunking of policymakers' narratives, and I think we see too little, and we have too little of that type of work and of that type of research following the implications of policy making and understanding what the implications really are of policies that have been implemented before. Okay, root cause number 4. It says idiosyncrasy of the dental research and the academic ecosystem. I think we see a lot of problem descriptive research. We see much less problem solving research. There's a lot of description of oral health inequalities, but we see much less concretely actionable recommendations. What really works to reduce inequalities in oral health? I think we also see major gaps in evidence to inform policymaking. I already mentioned that. And we also see a slow trajectory of methodological innovation. Till was mentioning causal inference. I think similar observations apply to health economics and implementation science. So there's a massive agenda ahead and massive room for improvement. So yeah, just to say that, I think we have, I almost said a problem, I think we have a challenge, so we should accept that challenge, and we are already in the midst of that. There's a clear need for improving our health systems. So far we see very slow progress in transformative change, and there are substantial gaps in collective problem solving. I think there's a lot of circular problem descriptive reasoning, and rarely there are breakouts from that paradigm. We have a lack of know-how, and we have a lack of know-do. And I'm coming to the third and final part of this talk. So this is about looking ahead, what's coming up in the future. So if you were hoping that oral diseases disappear all of a sudden and there are no more oral diseases, you're very likely wrong. So here's a forecast for the next 30 years, and you see this, okay, there's an uncertainty interval, but the midpoint estimates indicate that incidence rates for oral conditions likely will increase and keep increasing, unless we see a major turnaround or a major innovation breakthrough and so on. But most likely this is going to look like this. Okay, so this is what we think we can do to help improve the situation. So on the left side, the root causes of our health systems and failure, and on the right side, things that we are already doing and we most likely will be doing more in the future. So on the lack of accountability for citizen values, we are not only doing participatory research in EU projects. One of our EU projects is called Deliver. This is focusing on quality improvement and engages very closely with citizens, policymakers, and providers. But I think it's also important to point out more clearly what oral health means for social progress. Till already showed one example of theoretical considerations on this. So we're still in early stages to operationalize this, but pointing out the role of oral health as a marker of social progress more clearly, I think can go a long way. On the root cause of separation of oral health systems from the rest of medicine, we have been doing practice-based trials on integrated care. There's also community-based trials coming up. I'll give an example later on. We also engage in projects where there's no oral health at all involved. So we focus on projects looking at stress at the working place or stroke in Nepal. Because we think it is important to be present and understand also like how other research communities are working and get an opportunity to contribute, and that is a way of engaging, and then hopefully also we can do the favor in return and invite others outside who have not previously been worked on oral health into our projects in the future. On the root cause of path dependence in the oral health policy ecosystem, we have projects with focus on health financing. I'm not going to repeat what Till has said already. So one example is the EU Prudent project. We are collaborating with WHO and involved in projects with World Bank and member states. And on the dental academic ecosystem, we think it's important to invest in capacity building. So that's continuous optimization of competencies and also a regular updating of research portfolios. Looking broadly at oral health systems, the challenge is to make careful choices throughout the entire oral health systems. So that includes considerations about human resources for oral health, speaks to public benefit packages and the design and inclusion, what interventions should be part of public benefit packages, and also the design of appropriate incentives for providers, but also for patients. So you see this whole array of different intervention opportunities ranging from public health prevention to chair-side clinical care, chair-side restorative care, and the challenge is really to find the right balance. We will most likely always need some chair-side restorative care, but the question is how much of it, and wouldn't it be better to move more towards the left, more towards public health prevention, and how to achieve this. And it's not going to happen overnight. This is going to be a transition process, scaling down avoidable restorative care, hopefully, and scaling up more prevention of oral diseases. Just for illustration, I think we have a mismatch between evidence demand and evidence supply when it comes to oral health policy making. What I mean by that is that the type of questions that policymakers ask do not resonate in the research agendas we see in oral health research many times. So there's a lot of research conducted, a lot of evidence being created in oral health research, but it rarely gives answer to the type of questions that policymakers are asking. And that gives uncertainty, room for interpretation, and makes it difficult for policymakers to make better decisions. What we should be doing instead is, of course, have more crosstalk between policymaking and research, and reorient the creation of evidence more towards what's helpful for policy decision making. Here are three key ingredients which are important for evidence-informed policymaking. First, shared normative goals. Second, a shared understanding of health systems. This is about speaking the same language. And third one is to better match evidence with decision making. Here's an example of a normative goal. This is the WHO goal of universal health coverage, striving to have everyone get access to quality services without financial hardship. So this involves questions around who should be covered for which type of oral health services, and how much of the costs involved should be carried by patients, how much of the cost should be carried by the public. And that gives directionality, that triggers discussions, that sets the scene. When it comes to understanding oral health systems, here's a suggested taxonomy. And this is the type of questions that are being asked in the policy-making sphere. So there's stuff on governance arrangements, there's stuff on financial arrangements, there's items on delivery arrangements, and then implementation strategies. So just picking a few examples, important questions to ask are in the governance array are around consumer and stakeholder involvement. So how do we make more clear what the preferences and expectations are of patients with regard to the type of interventions that helps them improve their oral health. In the financial arrangements, there are key questions around how do we pay providers. Till gave an example of our work in this field. And delivery arrangements, I think a key question in the oral health field is who provides care and who's able to provide care. This is about skill mix, but it's also about in settings where there are no dentists at all, thinking of low-income countries, is there a role, for example, for community health workers? So this is the type of questions which are important in oral health policy making. We also have considerations around which type of evidence is suitable to inform which type of decision making and which step in decision-making processes. So, put it simply, there are 4 steps of decision-making. First, you figure out what the problem is, try to understand it, and what the causes of the problem are. You then identify options to address the problem and select the most suitable option. And I think, like in the oral health field, these are the 2 steps we are focused on the most so far. But we should be moving on much further beyond that and to the 3rd and 4th step as shown here. So it's about identifying implementation considerations and after implementation, keep monitoring and evaluating what the impacts were. I gave a brief example of policy evaluation after reduction of public coverage in the Netherlands. I think this is the type of information that would be really helpful to see more in the future. And for all of these steps, there's different types of evidence. You see considerations about data analytics, on modeling, so these are simulations. There's also a huge role for qualitative insights, but it's really the combination and being smart and clever on what type of information is best suited to inform which type of decision making. And in the end, if we combine this all together and do this over and over again over time, this might lead to a culture of learning and improvement. And here's the notion of learning oral health systems, where in the first step it's always watching out, understanding the situation, screening, understanding what the current issues are, like what is the problem. After we have understood the problem better, start co-designing new interventions, new services, and then implement those and monitor those. Like this paradigm repeated over time, it might sound simple, but it's not what we currently are doing, and we should be doing more in the future. I think this paradigm provides strong opportunities for creating new types of evidence, and over time improve the resilience of our health systems. And I want to give you some examples from our recent work. I think Benoit is online. This is in collaboration with the Oral Health Unit at WHO. We've been focusing in this collaboration on prioritizing cost-effective oral health interventions using the WHO choice framework, which has pros and cons. I don't have the time to zoom in on that now. But interventions considered so far included fluoride toothpaste, atraumatic restorative treatment, silver diamond fluoride, sugar-sweetened beverage taxation, and tobacco control. And yeah, there's more work to do in this field. This is the Prudent project. Again, Till already mentioned, so I don't want to bore you too much with that. But one part of the Prudent project is looking into workforce planning based on people's oral health needs. And Steve is here today. He has been working on this for a very long time, also very broadly, not only in the oral health context. And what this work is looking at is to get smarter and better in getting the right numbers and right types of providers to provide the type of care that people really need. As of now, in most projections and most workforce planning activities, these are based on fixed provider to population ratios, assuming that for a particular number of people, say 100,000 people, you need a particular number, you need a specific and fixed number of providers. But that's making the assumption that mobility will never change, that technology will never change. And of course, based on that assumption, you get the projections of future or providers wrong. You either get too many or too few, but the mix is not right. So what we're doing in this work is to start with understanding population oral health needs in the first place, then figure out what is the adequate type of interventions that would be most suitable to address that need, and then only in the third step we figure out who could provide that care. So these are questions around which type and which number of providers can provide that care. So this is oral health needs-based planning, and I think this is crucial in the oral health field, which has a long tradition of fixed provider to population ratios. The Deliver project, mentioned before briefly, this is focusing on quality improvement. And the main focus here is really on engaging with citizens, patients, providers, and policymakers. And we distinguished 3 levels for doing this. We don't think that quality improvement works only on the level of dental practices, which is classical quality improvement. But we focus also on the community level and on the policy-making level. We're actually getting towards the 4th and final year of this project. What we've done so far is, in the first phase of the project, we were doing situational analysis. First look out, watch out, screen, like how is the world working in quality improvement in the oral health field. Based on that, we've been doing case studies in practices using patient-reported outcome measures to inform quality improvement groups, reflective feedback by dental practice teams. On a community level, this has been focusing on how to start conversations with people who currently don't have access to care. Think about homeless people and asylum seekers. I mean, how to start meaningful interventions to make them aware of the relevance of oral health and to get them access to care. And on the policy-making level, this is focusing very much on identifying, like, where should we put priorities, where should resources be allocated to, which allow practices to provide the right care at the right place. And in the end, we want to have like a toolkit which gives practical recommendations, has indicators that can be used by practices and policymakers, and these recommendations can hopefully be used more broadly. Here is the Dig into Perio project. Once again, this is the project in which we look into integrated care between diabetes and periodontitis streams. I don't want to repeat this, and I think time is also short. Here is a forthcoming RCT in a low-income country. And I know Rainer was waiting for this probably for a very long time, and we've been working on this for many years. So like we're now set to roll out a community-based trial in the Nuna region in Burkina Faso, in which we want to understand the feasibility and the impacts of having community health workers providing silver diamond fluoride, and whether this can improve the oral health situation in a low-income country like Burkina Faso. So yeah, we set to go. This was a long bureaucratic exercise and journey, but I think we're now there. Just repeating Tedros, there is no health without oral health. Let's add, oral health is critical to ensure social progress. So that's the point, I think, which is really worthwhile to extend on and make more clear and emphasize more strongly, and also build stronger narratives around. And there's some positive signs, actually. So just last year, the EU Regional Social Progress Index, for the first time ever, and I've not seen any other social progress index worldwide, which included a dental-specific indicator. So for the first time, we now see under the basic needs category, and that's also good to point out. Under basic needs, we now see an indicator which speaks to unmet dental needs, and I think this is leveling up the profile and the visibility of oral health, not just in the health domain, not just in the health sector, but social progress indices really look much broader, look into education, foundations of well-being, and also policy making outside health. So I think this is a positive signal, but there's definitely more work to do to operationalize oral health as part of social progress indices. Now, wrapping up, so I think the broken smiles reflect a failure of society to warrant basic human needs. And the key opportunity and challenge lays within policymaking and striving more towards strengthening evidence to inform policymaking. Our role, I see, in acting as a change agent for collective learning and improvement. So these are iterative cycles of improvement. So continuously screen the horizon, understand what are the most pressing issues for oral health policymaking, for oral health improvement, identify suitable programs and interventions, put them to test, based on that, extract the evidence, and keep learning. Doing this repeatedly over time, I'm convinced will help us improve our health systems in the longer run. Now with that, I have to thank a lot of people and keep them smiling or get them smiling. So the challenge I really see here is to not forget anyone. So let me thank everyone who has supported my journey and the journey of the teams I've been working with. Many thanks to everyone here today, in person or online. Particularly my family. Thanks, Mom and Dad. Thanks, Susanne. I really mean it. I would not be here without you. Thanks to the rector and the board members of the university, the dean and the board members of the medical faculty, and the medical managing directors and board members of the university hospital. Special thanks to Till, not only for your super nice words today, but also for supporting oral health intellectually and institutionally as an integral part of the Institute of Global Health. Yeah, this really means a lot. Thanks to my academic mentors. I think, I've briefly spoken to Hendrik. I don't know where he sits now. I don't see him. There he is. Thanks, Hendrik. Steve. Axel, I don't think he's here today. And Hans-Jörg Stähle, we briefly shook hands before. Many thanks to my team, and I'm really overwhelmed by seeing so many names here. So we've grown very, very quickly in the last 1.5 years. So thanks to Jenny, thanks Anshal, thanks Lena, thanks Patrick, thanks Michael, thanks Shaila, Tarek, Noor, Sushmita, Valeska, Michael, Simon, Ave, Carolina, Federico, Demetrio, Lisa Maria, Rajiv, Dan, and Johannes. Many thanks. Special thanks to Jenny, who made the impossible possible to organize this event. Thank you. Many thanks also to my colleagues and friends from the Netherlands who are here today. I think I spotted Emily, Ingrid, Jip, Siet, Ilko, and Geert. And I think we actually have people attending from all continents. Some traveled far. Thanks, Steve, for coming in from Australia. Thanks, Kristen. Thanks, Michael, for coming over from the US. No, I'm lost. It's a really long list. Thanks, Jan, for coming from Dundee. and for making the effort to be here in person. Many thanks also to our colleagues from Nuna in Burkina Faso, particularly Ali and Mamadou. I'm not sure whether they're listening in, but really many thanks for a lot of hard work on the trial that we are set to go now. Special thanks to Benoit and the WHO Oral Health team. I think they are online, and we are really looking forward to keep working together. I'm afraid it would take too long now to name everyone in person. So yeah, many thanks again to everyone who has supported my journey and the journey of my team.